we all have patients who are sometimes functionally monocular. They have a better eye and a worse eye. Just by bad luck, sometimes they have an issue that affects their better eye. And you want to treat it, but you think, well, if I cover their better eye with an amniotic graft and the graft is opaque, and now they're further visually compromised than they were, this is going to impact their activities of daily living for the duration of treatment. Maybe it creates a safety issue for them. If they do misstep and get hurt, how does that affect me in terms of liability? So what we wanted to do, and to be fair, not every, and then you have patients who have two wonderfully functional eyes, but the defects are not always involving the central cornea. In many cases, they're outside of that pupillary zone, or you're treating staining or some epithelial compromise or a condition that's manifested itself really outside of that pupillary zone. So you don't have to cover the central cornea. So what we did was we looked at making a graft that has an aperture in the center that we figured 5 millimeters is about where you want to be for most people. Most of the time, that's going to allow them to have normal vision. And that's the Aurora graft. It's a 10 or 12 millimeter diameter disc that's got the central 5 millimeters punched out, and that's helpful for three reasons. One, it lets the patient still be able to see normally. Two, it allows me to see into the eye if I want to. Let's say that we have a patient who has herpetic keratitis and I want to monitor what's the anterior chamber reaction as a way of assessing if things are improving or not improving with antiviral treatment, while the amniotic graft is working on stabilizing the cornea, quieting down what's happening on the cornea, minimizing the risk of minimizing the risk of corneal scarring, and minimizing the risk of neovascularization. All that stuff the graft is doing, I can still look into the eyeball and make sure that the anterior chamber is going in the right direction, the reaction is going in the right direction. The third thing is, if you think about the two main concerns you have when somebody sleeps with a contact lens on, right? The two main concerns you have are infection and oxygen. And that's whether they have an amniotic graft on or not. It's infection and oxygen. So they have the graft on the eye. There's a bandaged contact lens on top holding the graft in place, protecting the graft position, and and allowing the graft not to be shifted or knocked off by blinking or maybe minor eye touching, things like that. The contact lens helps keep it in place. But to lower those risks of infection and hypoxic sequelae, we found a couple things. One, the thinner the graft is, the better. Two, if we can have them use lubricant drops that support the exchange of fluid and oxygen under the lens, that's better. Three, while oxygen does get into the cornea from the tear film, it doesn't really go very far sideways, So if we could spare that central part of the cornea from being covered, then we could really, really, really reduce the risk of any hypoxic sequelae occurring within that central pupillary zone, which is huge because not just from a patient protection standpoint, we're safeguarding the patient's vision on the back end, but from a prescriber or a practitioner liability standpoint, if there was, let's say the patient didn't get the combination antibiotic steroid drops that I might have recommended, the antibiotic component keeping most common ocular surface pathogens in check, the steroid component helping to safely, keep the patient comfortable, but very effectively and safely offset the risk of significant hypoxic sequelae, corneal edema, infiltration, ulceration, anterior chamber reaction. All that stuff is safely kept in check by the dexamethasone component that's in commercially available combination antibiotic steroid drops. Let's say they didn't get those drops. Let's say they didn't get the non-preserved lubricant drops because they cost $25 or whatever it is. And now they do wake up the next morning, they go to sleep, and as they're sleeping, they're not blinking, there's no fluid exchange under the lens. The resultant oxygen permeability of membrane plus contact lens plus closed eye really approaches zero. And now they wake up with this hypoxic reaction going. What I can tell you is that the infiltrate or ulcer or whatever it is isn't going to be central. If that was to happen. Now, most patients, most of the time, I found to be very compliant. They do pick up the eye drops the same day. They do what's expected of them, and they stay out of trouble. I've probably done 700-ish cases. I haven't had any central corneal complications at all. I've had maybe 3 folks who got peripheral hypoxic infiltrates. But that's, again, because the grafts that we used at that time were thicker. Patients didn't pick up the drops as expected. They didn't get their combination antibiotic steroid drops. They didn't use their non-preserved lubricant drops. and then some of these people get popped up. But with the Aurora graft, again, it really takes that risk of a central hypoxic event and pushes it down to zero-ish. Allows the patient to maintain normal vision during the course of treatment, and allows me a view into the eye as well. So I thought those were important points, and I did talk to the folks at Ophthalogix who played around with the design, and in the end we have a finished product that I can say works really well.